Hello and welcome to the session today. Today we're looking at respiratory disorders. Guys, the respiratory system includes the lungs, the airways, the blood vessels, the musculature that normally facilitates breathing and gas exchange. So there's a range of conditions that will normally compromise the respiratory functions, and this could include inflammation, also the allergies and the asthma, could be infections like pneumonia, bronchitis, cold, the flu, or diseases like lung cancer, COPD, lung damage. So all these can lead to respiratory compromise. All right. So meds that will be used to help us in helping the patients in this case is the respiratory drugs. So they manage symptoms like coughing, wheezing, shortness of breath, chest tightness for that case. So we could have different classes for this system. We could have the major drugs, that is the bronchodilators, or the anti-inflammatory drugs. So these drugs can be broadly classified into those two groups. So for the bronchodilators, they help in bronchodilation, so the airways are kept patent, so we can have exchange of gases in and out. So for the bronchodilators, we have a number of them. We could have the sympathomimetics. In sympathomimetics, we have the short-acting agonists, that is, we commonly refer to them as SABA, and the long-acting agonists, the LABA. Okay. In addition, we also have the ultra long-acting, okay, the ultra LABA drugs. These are a unique group of drugs because they are approved to be used in COPD and not asthma, and that is very key for us to know. So apart from the sympathomimetics, these are just basically beta 2 agonists. Okay, so they do activate beta 2 receptors, which leads to an increase in CMP. And when you have the cyclic AMP normally relaxes the bronchial smooth muscles. So one of the major mechanisms you need to use to cure this is increase the CMP, and the bronchial vessels will be dilating. So that means we'll have perfect gaseous exchange. The second group of bronchodilators is what we refer to as anticholinergics, and this one they just bind to the M1, M2, M3 muscarinic receptors. Okay, of course, we're going to see that the main muscarinic receptor in this case is the M3. Okay, is the M3. So we could have drugs like ipratropium, tiotropium, imidaclopium. So just like we had looked at the sympathomimetics, also here we have the short-acting and long-acting. Okay, so we'll have long-acting muscarinic antagonist. Okay, so we'll be having the SAMAs and the LAMAs in this case. Then lastly, we'll have the PDE inhibitors, okay, phosphodiesterase inhibitors. Okay, so these ones, they are going to exert their effects on the targeted phosphodiesterase enzymes. Remember, for the sympathomimetics, they are bringing about their effect by increasing the availability of the CAMP, the cyclic AMP. And when you have cyclic AMP in abundance, it means that you are going to be having your bronchial tree is going to dilate. Okay, so you find that phosphodiesterase enzymes they normally degrade the CMP. Okay, so if you want to increase the CMP equally, you could just work on these enzymes so that they are not available to degrade the CMP. So that means the CMP will be more available for this case, all right? So that is what we also need to know, and this is what we are going to get from the PDE inhibitor. So we could have a range of drugs here. We could have the benzaldehydes, like the theophylline, and now we have another drug here, the roflumilast, okay? Roflumilast, okay? It's also a common drug that we are going to be having in this case. So we could start off by looking at the bronchodilators, which you have already at least mentioned. You know that the mechanism of relaxation in this case, we are going to increase the cyclic AMP. So those could be the mechanism of action. We're going to increase this CMP, and we are going to decrease acetylcholine. Acetylcholine is a neurotransmitter that normally activates the muscarinic receptor. So we're going to reduce its concentration, and we are going to increase the concentration of CAMP of the CMP. So generally, the bronchodilators, they work by relaxing muscles around the airways, and this normally helps widen them and makes breathing in and out easier. They are commonly used to treat conditions like asthma and chronic obstructive pulmonary diseases. So we could have beta agonist, as we had said, and for example albuterol, this is a short acting agonist, and salmeterol, this is a long acting agonist. Anticholinergics, we have also mentioned ipratropium and tritopium. So ipratropium is a SAMA and a tro is a LAMA. Then methanexims like the theophylline, and then we also look at roflumilast. All right. Okay. So start with the sympathomatics. And sympathomatics, we have already said we could have short-acting beta agonists or long-acting beta agonists. In addition, we also have the ultra-long. Okay, so generally the beta 2 receptor agonists that are normally administered via inhalation, and when they are inhaled, they do bind to beta 2 receptor agonists, which normally leads to relaxation of the bronchial smooth muscles, and this is majorly through increased potassium conductance and increased CMP. So we could have albuterol. Albuterol is the prototypical agent of short-acting agonist that is normally administered via inhalation with a rapid onset, and it's normally used as a rescue inhaler. Guys, which one is used as a rescue inhaler? Albuterol, short-acting beta agonist. All right. So albuterol is not used for everyday asthma, okay? It is only used as a rescue inhaler. That is what you need to know. That is very key for our discussion, guys. So we could also have other examples of short-acting beta agonists like the terbutaline or metoprolol or bisoprolol, and they are majorly administered via inhalation, as we have already indicated, and their onset is of action is within 5 minutes, and they are just used on assist base, okay, assist base. So they are only rescue inhalers, okay. All right. So we could also have adverse effects of this short-acting agonist. Guys, I want you to understand that these beta agonists, they normally activate receptors, and they activate beta 2 receptors. And when you talk about beta 2 receptors, we also have other types of beta receptors like beta 1 that is majorly found on the heart and just glomerular cells in the kidneys, and also beta 2 that is majorly found in the adipose tissue. Okay, so you may find that these other receptors are activated, okay, are activated. And that's why it is very key, guys. When you're using beta blockers, you have to use selective drugs in cardiovascular, because if you don't, if you use a general one like propranolol, it's going to bind to almost beta 1, beta 2, beta 3, and you're going to have a number of side effects. All right. So in this case, guys, beta 2 agonists, they're going to be activating the beta 2 receptors. Okay, so sometimes you may find that they have also activated these other receptors. So you can imagine if they activate beta 1 receptors, which are found on the heart, what will be the side effect? Because they're increasing their activity. So that's why, that explains why we will have tachycardia, for example, for that case. Alright, so we could also have skeletal muscle tremors, cardiac arrhythmias, and receptor desensitization. Okay, in homologous desensitization, we have continued beta 2 stimulation, which could lead to receptor desensitization, which now further leads to downregulate receptors on the membrane, thereby decreasing the efficiency of this very SABA. Okay, so SABA receptor is degraded. It results in decreased receptor number on the surface, leading to decrease in efficiency. So that's a common conditions that we have to be aware of. Now, guys, after looking at the short-acting beta agonist, we can also now spend some time and look at the long-acting beta agonist. Remember, when you compare this short and long, short are going to be slow in action. Okay, so they will not be used as a rescuer. All right. Okay. And so this one you expect it to be used as a maintenance, all right, as a maintenance dose for this case. And the prototypical drugs here could be having Sameltrol and Formeltrol, right? So Sameltrol has an albuterol head on the molecule that can interlect itself into the membrane of cells, and this can stimulate multiple beta 2 receptors. Formeltrol, on the other hand, it intercalates with the lipid membrane from which it is slowly released to bind to beta 2 receptors and the lipid membrane that serves as a storage depot. Okay, so duration of action for Someltrol and Formeltrol is about 12 hours. So that means they require like 2 dosage, okay, in a day. Adverse effects are close to the short acting. So like now activating receptors, like if you activate the B1, you're going to result into increased heart rate for that case, and then arrhythmias. Okay, long-acting beta agonists are normally used in combination with fluticin or imetinib, that is inhaled corticosteroids. Okay, they are used in combination with inhaled corticosteroids, the LAB. All right. Okay. From the LABA, we have the ultra LABA, okay, the ultra long-acting beta agonists. So they are not indicated for treatment of asthma, but they have been approved for COPD. And the main reason is that they normally cause receptor desensitization. Okay, so examples of the ultra LABA, we have the intercatrol and olocaterol. Okay, and the duration of action for these two drugs is about 24 hours. So they just require single dose in a day. So they are not approved for asthma, we have already said, because this can lead to receptor desensitization, right? Okay, so from there now we can go and look at the anticholinergics, okay, anticholinergic drugs. So the anticholinergic drugs, we're going to be talking of the SAMAs and the LAMAs, okay, short-acting muscarinic antagonists, all right. So we have these anti-muscarinic agents. So these anti-muscarinic agents, they block muscarinic receptors, and the muscarinic receptors could be the M1, the M2, the M3. So This case, they will decrease the stimulatory effect of acetylcholine on the bronchial smooth muscle contraction, leading to relaxation. So they do what, guys? They are also commonly referred to as drying drugs. Okay, they dry our body. They block secretions. Okay, guys, so they block secretion in our eyes. Of course, so those patients, they can't pee. Okay, they can't pee. Yeah, they can't vomit. Where is the secretion? The secretions are not there at all. Right? They can't defecate. Okay, so there are no secretions at all. So these drugs, they normally block M1, M2 and M3 receptors, leading to slow development of bronchodilation and can prolong the action of beta 2 receptors. Okay, for our class, guys, it's important to know that the main target for antimuscarinic drugs for our case is the M3 receptors. Okay, okay, so when you talk about the summers and the lamas, okay, so like the ipratropium, this is a prototype agent for the short-acting antimuscarinic agent. It's normally administered by inhalation and has a duration of action of about 4 to 6 hours with an onset of about 1 to 3 minutes. Okay, this drug should never be swallowed, and that's what you really want to know and insist and talk to the patient about it. While the ipratropium will be the prototype agent for the long-acting antimuscarinic agent, the LAMA, okay, and this one is normally administered via inhalation and has a duration of about 24 hours, needing just once daily dosing. Okay, we also have a new drug. It's called the rifampicin, and this is a LAMA that's a newly agent, and this one can be administered simply by a nebulizer. Okay, adverse effects of antimuscarinic agents, we have said already, antimuscarinic agents, they dry our body. Okay, so patients are going to present with dry mouth, no saliva, blood vision, not tears, guys. Okay, mydriasis, tachycardia, constipation, urinary retention. Okay, guys, so those are the side effects of these anti-muscarinic drugs. Okay, so what are you supposed to tell the patients? Tell the patient to chew gum, chew candy, drink fluids. Okay, so as at least to replace those fluids there. Okay, contraindication for these antimuscarinic drugs will be in patients who are already dry, guys. Patients like glaucoma who are having issues with the drainage. In that case, you don't need to give them these drugs. Patients who are having urinary retention and BPH, bowel obstruction, should not be given these antimuscarinic drugs for that case. Okay. So guys, we have already looked at what? Sympathomimetics could be short-acting, long-acting agonists. Alright? Then number 2, we have looked at the anticholinergics. It could be a short-acting antimuscarinic drug or a long-acting antimuscarinic drug. All right, so now we're going to look at another group of bronchodilators, and that's what we're talking about, the PDE inhibitors. Okay, phosphodiesterase inhibitors. Okay, and one of it is the methylxanthines, specifically the theophylline. Okay, all right, so theophylline normally blocks adenosine 1 receptor and also the PDE to inhibit bronchoconstriction, tilting the balance to the bronchodilation. All right. On the other hand, we have the Rofulimast. It will block the PDE receptors. All right. So we have already said the PDE is an enemy to the CMP because it degrades the CMP. So if you block the PDE, then that means the CMP will be there in plenty and it will keep our bronchial tree dilated. So that is what we really want to know. Remember, when you look at the bronchial tone, you normally have the bronchodilation and bronchoconstriction. So for bronchodilation, we need to have an increase in CMP. Okay, then for bronchoconstriction, we have the increase in adenosine, all right, or acetylcholine. So we just need to suppress this one, and increase this one, and we have achieved our broncho and our bronchodilation, all right? Okay, so that is what we need to have. So when you start with the theophylline, of course, we have already said it increases the CMP concentration, and this is by inhibiting the PDE to tilt to bronchodilation. So bronchodilation leads to increased vital capacity, mucus clearance, diaphragm contractility, and decreases inflammation and fibrosis. Theophylline is normally administered orally, but is not used commonly because of its narrow therapeutic index. Okay, remember the normal range for this therapeutic index for this theophylline is between 10 to 20, right? So we could have tachycardia, agitation, restlessness, anxiety, fear, panic when the concentration are greater than that, okay, greater than 20, okay. Furthermore, we could even have convulsion and death could occur when the theophylline plasma concentration are greater than 40. So it's also good to note that a rapid infusion of theophylline could also result in sudden death and cardiac arrhythmias. So this means the RN has to keep and watch on these levels, okay, the theophylline levels, for us to keep the patient safe for this case. So phosphodiesterase inhibitors and another one like the Rofulimast, and this Rofulimast is a selective phosphodiesterase 4 inhibitor, and it's indicated to decrease the risk of exacerbations in patients with severe COPD and also to treat plaque psoriasis. So it's used to reduce the risk of COPD exacerbation in patients with severe COPD and chronic bronchitis with a history of exacerbation by just simply inhibiting the phosphodiesterase, okay, in the lungs, leading to reduction in inflammation and fibrosis. So if a patient is taking a strong inducer of cytochrome 450, then it means that the effectiveness of Rofulimast will decrease because it's also metabolized by the cell. However, if you take a cytochrome 450 inhibitors like erythromycin or cimetidine, this will allow Rofulimast to build up in plasma, okay, and thus you'll be able to experience more side effects of the same drug, okay. Okay guys, so that's the end of the bronchodilators. So from there we can now go to anti-inflammatory drugs, okay. We have the CLM, the corticosteroids, we have the leukotriene modifiers, and now we have the mast cell stabilizers, CLM, okay. So anticholinergic drugs, they reduce inflammation in airways, and this helps to prevent and control symptoms in conditions like asthma and COPD. They include drugs like corticosteroids, okay, like the steroids like the prednisone or the fluticasone, and these steroids you can simply identify them using the SON, okay, the SON. We also have the leukotriene modifiers like the Montelukast, okay, the Montelukast drug. And lastly, we now have the mast cell stabilizers like the cromolyn sodium, okay, the cromolyn sodium. So guys, we could appreciate different drugs here, guys. We could have the chromons, the mast cell stabilizers, the cromolyn sodium. We could have the glucocorticoids, both inhaled and oral, okay, for that case. Remember, when you're using the oral corticosteroids, you have to rinse them out and you have to use the spacers in order to prevent the thrush. Remember, steroids, they decrease our immunity, so we become more susceptible to developing this opportunistic infection. So that should be done for the case, okay. So here the inhaler for the steroids is normally cleaned with warm water after every session, while the inhaler for the rescuer could just be cleaned 1 or 2 times in a week. Okay, but for the steroids, every time you have a session, you have to clean it. Okay. Leukotriene receptor antagonists like the Montelukast, okay, of course these are examples of competitive antagonists at the CILT1 receptors, okay, and given over 1 to 2 weeks. We also have the leukotriene synthesis inhibitors like the Xylantone, and lastly the biologics like the omlizumab. Okay, it's used as an add-on therapy only for asthmatics with high eosinophil levels, and it's very expensive. Unfortunately, it's also a protein, so it can again cause anaphylaxis. Okay, so that's how tricky this drug is for that case. So starting with the chromones, of course, these are mast cell stabilizers. They are used prophylactically to prevent inflammatory attacks, and regular use decreases bronchial activity. Cromolyn sodium is the only nebulizable solution for asthma, and over-the-counter nasal spray is also available. Okay. It also decreases, the sodium decreases mast cell activation to decrease histamine, leukotriene, and cytokine release. So activates a turn-off switch that is normally linked to a chloride current that opens calcium channel to reduce calcium influx into cells to decrease the release of inflammatory vesicles so as to reduce degranulation and release of mediators. That is, inhibits degranulation to decrease the release of mediators for that case. Corticosteroids, on the other hand, they bind to glucocorticoid receptor in the cytoplasm, and this causes the complex to translocate to the nucleus. We could have examples like the flutocin, the budocin, the beclomethacin, metazone. Okay, their dose and concentration normally affect acylation of histones, so know that the acylation of these histones will keep the DNA wound around the histone so that gene transcription is repressed. So at low dosage of glucocorticoids, you find the GR complex translocates the nucleus to inhibit the heart, which decreases gene transcription and formation of inflammatory proteins that decreases inflammation for that case. Okay. But at high dosage, the glucocorticoids, the GR complex will bind together after translocating to the nucleus, leading to acetylation of histones, allowing for unwinding of DNA, so that gene transcription occurs, resulting in formation of anti-inflammatory proteins to decrease inflammation. So we have different cell types that are inhibited with the usage of glucocorticoids. We have the eosinophils and basophils. Glucocorticoids decrease inflammatory proteins by reducing the echinoids synthesis, thus reducing the release of cytokines, chemokines, chemoattractants, and adherent molecules. Okay, so we could have the glucocorticoid side effects, okay, like opportunistic infection because the sugar decreases, right? That means the inhaler, they have to be cleaned once you are done with the session, okay? This is contrary to the rescuer where we just cleaning it twice a week, okay, once or twice a week, okay? So others who could have dysphonia, decreased bone mineral density, resistance can also develop. Okay, so we have disturbance in mood, have increased appetite, increased glucose control, impaired glucose control, susceptibility to infections, and adrenal insufficiency upon rapid withdrawal. Okay, fine. So the others we have the other anti-inflammatory, we have the leukotriene synthesis inhibitor. Leukotriene synthesis inhibitor, and a good example is the Xylantone. It's contraindicated in patients with liver disease or those who consume large amounts of alcohol. So it works by inhibiting an enzyme 5. Lipoxygenase that normally inhibits the formation of CLTs to decrease the amount of CLTs available that will stimulate the production of chemotactic anticoags. So it decreases the attraction and migration of leukocyte to an area of inflammation. So stimulation of these receptors is responsible for bronchoconstriction, edema, eosinophil activation, and is competitively inhibited by these drugs. So Xylotine is normally administered 4 times a day, limiting patients' adherence. All right. So we also have the mucolytics, and the mucolytics, these are drugs that help thin and loosen mucus in the airways, making it easier now to cough them up. Okay, they are often used to treat conditions like chronic bronchitis and cystic fibrosis. So examples, we have the acetylcysteine and the docin alpha. So mucolytics are drugs that providers use to treat chronic lung and breathing conditions. They break up mucus in our lungs and makes it easier to cough them. They are mostly commonly used in a nebulizer to treat cystic fibrosis, and the most common side effects include stomach ulcers and voice changes. So from there, after looking at the bronchodilators and anti-inflammatory drugs, there's now what we call now the combination inhalers, where you combine a bronchodilator and an anti-inflammatory drug. So some medications can be combined. So this will provide a comprehensive treatment for this respiratory condition. So combination inhaler is effective in mild asthma. Combination inhalers can also be used every day to help stop symptoms occurring and provide long-lasting relief if they do occur. It's important to use it regularly, even if you do not have the symptoms. Okay, so side effects of this combination inhaler are similar to the reliever and the preventer inhalers. Some medication combination could include like fluticin and salmeterol. Okay, we also have the budesonide and the formoterol, like the Symbicort. All right, and also have the monefin and voneg. All right, and we also have the fluticin and the vilantrol. Okay, we could also refer to as the preolinter. Okay, metazone and formoterol, the Dulera. Okay, and also the fluticin and salmeterol. We also have the Atea. Okay, all right, so these are some of the examples of these combined inhalers. So the other drugs, we could also have antibiotics. So in cases of respiratory infections caused by bacteria, antibiotics could be prescribed to help fight the infections. And common drugs include amoxicillin, which is a penicillin, azithromycin, which is a microlide, and levofloxacin, which is a fluoroquinolone. Guys, a link will be popping up on the different type of antibiotics you can review to find the mode of mechanism for such kind of drugs. Next, we have the antiviral drugs. So these drugs will be used to treat certain respiratory infections that are caused by viruses, which include the influenza virus, the respiratory syncytial virus. Examples, we have the oseltamivir, that's Tamiflu for the flu, and ribavirin for the respiratory syncytial virus. Okay. Remember, rifavirin specifically binds to the substrate binding site of the INPH enzymes, limiting access of the enzyme to its endogenous substrate, ultimately leading to decreased synthesis and lower levels of the GTP. All right. So we could have examples of the Tamiflu, oseltamivir for that case. Lastly, we have the immunomodulators, the biogenics, okay, drugs like omzalibab. Okay, the omzalibab is a biological agent that binds to immunoglobulin E. So it's not free to bind to receptors on mast cells, thus decreasing activation of the synthesis and release of leukotriene and cytokines. It's normally a subcutaneous injection, okay, and it's used to treat. And of course, you need the people, the eligible people, they should be at least 6 years. Okay, at least 6 years. Okay. So they have side effects. The severe cases could lead to allergic stomach. Omzalibab binds to free IgE, which you have already said, and this lowers Ig levels and also decreases the receptors on the basophils and mast cells, which leads to down regulation. We also have other types of immunomodulators like the mepolizumab and reslizumab. These are drugs that normally blocks the interleukin 5 to prevent recruitment and maturation of eosinophils. We also have another one, benralizumab. This is a drug that will bind receptors for the L5 to prevent recruitment and maturation. Okay, maturation of these eosinophils. All right, guys. So guys, what happens when you have an attack? How should you be able to approach it, guys? Okay, how should you be able to approach it? When you are having this asthma attack, we normally aim to treat these drugs using the best reliever first, followed by these other drugs. Okay, so like we use the aim. So we start with the short-acting beta-2 agonists. There's some which is albuterol. So albuterol first, then you can go for anticholinergic, of course a short-acting anti-muscarinic drug, the ipratropium. Then you can have the steroids. Okay, remember when you are using an inhaler, you have to shake the inhaler well before you use, and then you breathe out, then take the puffs, hold it for some seconds, then exhale. You have to instruct the patient to take 2 to 4 puffs for every 20 minutes for around 3 rounds. If not working after the 3 dosages, you have to inform the healthcare provider. Remember, we can only say that drug is effective when the respiratory rates are decreasing. Of course, in an asthmatic attack, they are elevated. So decreasing, that means the drug is becoming effective. And when you look at the oxygen saturation, it should be at least 90%. So if you're using both, that is a bronchodilator and anti-inflammatory, especially the steroids, remember to start with albuterol, then steroids. Steroids are slow in action, so don't start with steroids, please. You have to start with albuterol. Okay, so the inhaler should be cleaned with warm water 1 to 2 times a week for the rescue. Okay, if it's a steroid guy, it has to be cleaned every time you have a session. Okay, so only steroids are cleaned after every use. Okay, steroids should be cleaned after every use. Okay, guys, so that wraps the end of our video on the respiratory drugs. Remember, we have looked at the bronchodilators, okay, and we also looked at the anticholinergics. Thank you so much. You can access the free quiz on the video in the description section. Okay, you can access all the free quizzes regarding the respiratory drugs there, and we can have discussions of it. Thank you so much.